For decades, standard clinical practice has treated chronic non-malignant pain, insomnia, and depression as three entirely separate pathologies. Doctors attack them as isolated targets. A patient receives opioid therapy for the physical pain, an SSRI for their mood, and a hypnotic sedative for their sleep. This fragmented strategy yields exceptionally high clinical failure rates, leaving patients trapped in a state of compounding distress. Current literature identifies these as a highly coordinated, self-sustaining loop. Each symptom actively manufactures the biological conditions required to drive the other two. Clinicians now define this unified neuroinflammatory feedback loop as pain insomnia depression syndrome, or PIDS. PIDS is a discrete clinical entity characterized by the dense pathobiological integration of these three states. Targeting the physical locus of pain while ignoring the patient's sleep and mood is mathematically doomed to fail. The underlying architecture of PIDS is a deeply interconnected system, and resolving it requires mapping the exact mechanisms connecting these nodes. The core tension of PIDS operates as a tridirectional engine. Pain drives depression, depression disrupts sleep, and sleep disruption exacerbates pain. This flowchart shows the clinical model of CPID, chronic pain, insomnia, depression, developed by Hadery and colleagues to map these exact interactions. The three distinct cycles map the permutations of this pathology. In pathway A, the simultaneous presence of insomnia and depression directly amplifies baseline pain intensity. The psychological and rest deficits act as a multiplier on the physical nociceptive signals. Looking at pathways B and C, chronic pain dismantles sleep architecture, which then directly triggers or worsens depressive symptoms. The physical discomfort acts as a continuous stressor that blocks the brain's ability to enter restorative states. To break this cycle, symptom management is insufficient. Clinicians must map and target the shared neurobiological architecture that powers the entire loop. If the PIDS loop is truly bidirectional, we have to determine which vector provides the strongest starting point for medical intervention. Population-based longitudinal cohort studies tracking pain-free individuals over 5 to 18 years reveal a severe directional asymmetry. Baseline sleep impairment is a substantially stronger statistical predictor for the future onset of chronic widespread pain than existing pain is for future sleep disruption. Difficulty initiating or maintaining sleep guarantees future physical pain at a much higher rate than the reverse. We can validate this asymmetry using objective polysomnography data from chronic and post-surgical pain patients. Polysomnography is a diagnostic test that comprehensively records biophysiological changes occurring during sleep. The data shows massive objective deficits. Pain patients experience up to an 80% reduction in total sleep time. They exhibit highly fragmented rapid eye movement blocks and a near-total elimination of deep, slow-wave sleep. Inside that slow-wave sleep, sensors detect abnormal alpha-wave intrusions. These high-frequency interruptions directly and strictly correlate with objective, waking pain measurements. This sleep deficit is an active, aggressive driver of central hyperalgesia. Hyperalgesia is an abnormally increased sensitivity to feeling pain, caused by damage to nociceptors or peripheral nerves. The data from sleep labs translates directly to physical alterations in macroscopic brain structures, specifically within the prefrontal cortex and the limbic system. Functional imaging reveals marked hypoactivity in the prefrontal cortex during states of chronic pain and insomnia. The region responsible for executive function and regulation goes quiet. This drop in prefrontal cortex activity leads directly to a dangerous disinhibition of the limbic system. Without the prefrontal cortex acting as a brake, the brain's emotional reactivity to pain signals drastically heightens. This schematic illustrates the shared neurobiological pathways that feed into this exact state of central nervous system sensitization. Multiple distinct physiological failures converge on the triad. We observe physical degradation within the limbic system itself. Structural atrophy of the hippocampus is a documented hallmark of both prolonged chronic pain and major depression. This reduced hippocampal volume is directly linked to suppressed neurogenesis and a severe loss of neuroplasticity. Neuroplasticity is the brain's ability to reorganize itself by forming new neural connections throughout life. The physical, structural decay in these macroscopic regions hardwires the PIDS loop directly into the patient's neuroanatomy. To understand how that structural decay occurs, we have to look down at the microscopic synaptic layer, specifically focusing on nociceptive terminals and the ventral tegmental area. The ventral tegmental area is a midbrain structure, vital for reward and pain processing. The primary molecular culprits here are systemic pro-inflammatory cytokines, specifically IL-1 beta and TNF-alpha, which are capable of crossing the blood-brain barrier. Once inside, these cytokines act directly on nociceptive terminals in the inflamed tissues, drastically increasing mechanical pain hypersensitivity. These cytokines possess a dual-action capability. Even in the absence of immune stress, high levels of IL-1 beta and TNF-alpha mimic the exact symptoms of sleep deprivation and actively suppress restorative slow-wave sleep in the brainstem. The brain attempts to fight this using an opposing protective molecular factor known as brain-derived neurotrophic factor, or BDNF. BDNF is a protein that promotes the survival of existing neurons and encourages the growth of new synapses. However, the continuous physiological stress of chronic pain and sleep loss severely downregulates the expression of BDNF in the hippocampus. This depletion of BDNF destroys any remaining neuroplasticity. Without it, the brain cannot repair the hippocampus, effectively locking in the depressive phenotypes and the heightened pain state. High levels of pro-inflammatory cytokines paired with critically low levels of BDNF create a toxic biochemical bath. This fluid acts as the infinite fuel source, keeping the PIDS triad burning. The lateral hypothalamus and the orexin system act as the central regulatory bridge for PIDS. Orexin is a neuropeptide that regulates arousal, wakefulness, and appetite via the OX1R and OX2R receptors. This graph maps the immediate biochemical reaction to sleep loss. Extended periods of sleep deprivation violently spike orexin levels in the cerebrospinal fluid. This unnaturally high orexin tone simultaneously blocks REM sleep and alters dopamine inputs within the ventral tegmental area. This orexin-driven dopaminergic shift in the ventral tegmental area forces a reduction in the body's pain threshold while simultaneously inducing deep depressive behavioral states. Orexin serves as the central biochemical knot. Its mechanics prove that sleep regulation, pain signaling, and mood control operate on the exact same neural circuit. Given this dense, shared neurobiology, clinical practice must determine which node of the triad to attack first to achieve maximum leverage. Returning to the tridirectional CPID model, we find that executing an upstream intervention on sleep architecture collapses the entire system. Attacking the pain node exclusively with analgesics fails because the central nervous system is already highly sensitized. It is overwhelmed by circulating cytokines and surging orexin. The drugs cannot outpace the biochemistry. The upstream target is sleep. Interventions like CBTI, CPAP therapy, or targeted orexin antagonism address the root. Cognitive behavioral therapy for insomnia is a structured psychological intervention that targets the behaviors driving sleep loss. Continuous positive airway pressure is a physical therapy, utilizing a machine to keep airways open during sleep. Resolving the sleep deficit physically starves the feedback loop. By reducing orexin and pro-inflammatory cytokines, the intervention intrinsically lowers the patient's nociceptive baseline without requiring a single additional analgesic. Empirical clinical trials validate this approach. Treating comorbid obstructive sleep apnea with CPAP machines consistently improves objective experimental pain thresholds and reduces migraine severity. Successfully improving sleep via CBTI in osteoarthritis patients effectively predicts long-term pain recovery and reduced clinical depression. In severe, refractory cases, advanced interventions like deep brain stimulation artificially reset this architecture, implanting electrodes to deliver targeted electrical impulses to specific neural regions. PIDS is a mathematically unwinnable battle for single-access pain medication. Effective treatment of chronic pain requires dismantling its shared neurobiological infrastructure, and the data shows that dismantling must begin